PI in one eye and the other eye has control and 6-year follow-up. All subjects are from South China, so ethnically not the same as us. And PACS, the limitation here is they will not use indentation gonoscopy, 2-quadrant or pigmented trap not visible. There's a posterior trap not visible. And no synechia or disc changes, and intraocular pressure should be less than 21. Those excluded were on provocativeness if the pressure went up, or on dilatation the pressure went up, or 30 mmHg at any point in time. They were sent into the standard of care, which is PI. Of these patients, about 454, they had OCT data, and they found that 26.4% had residual PACS. That means 1/4 of the patients who went through PI did not open up. And they came up with report as per 1,000 years, 4.19 per 1,000 years of PSC, not yet PSCG, that synechia occurred in 4.19 as opposed to 7.97 per 1,000 years in the untreated or non-PI eyes. So primary outcome occurred actually in 19 of the treated eyes post-PI and 36 during the 72-month follow-up that they had, mostly by development of PAS and not glaucomatous optic neuropathy. So they came up with an NT of 1 in 250 person years or eye years would benefit if we do a PI on all with PACS. So again the same thing, PI reduces the risk factor, risk by a factor of 2 is what they told us, but almost the same team, quite a few investigators being the same, did this analyst study as a follow-up on it. This is the symptomatic narrow angles laser iridotomy study. This is in Singapore, multicentric. And some of the factors which were considered limitations in the ZAP were taken care of. So here we had 480 individuals over 50 years, bilateral 2-quadrant apposition, PI in one eye and the other eye was a control. So its control has got all the demography matched. And the outcome, PAC, synechia or an intraocular pressure going up above 21 or PSCG or acute closure was defined at the start of the study. Again, most of them are Chinese, most of them were women. In the Singapore study also, 5% of the LPI treated went on to develop the endpoint in 5 years, as 9.4 went on to develop PSC in the control eyes. And the hazard ratio again was, it gives you that the PI gives you half the risk as opposed to no PI, but it does not prevent closure in all the eyes. But they did come out one more thing, that the hazard ratio goes up with older participants per year. There's an increase in the hazard ratio per millimeter of baseline in the intraocular pressure. As the pressure goes up, the hazard ratio goes up. So they were more likely to reach the endpoint or go on to develop a synechia if the PI was not done. The number needed to treat for the whole group was 22. 1 in 22 would benefit. Okay. The risk of progression reduces by half, but the absolute risk of progression without PI is not very high also. From analysts, we know that the older age group and higher baseline IOPs had a higher risk of progression. So you would go for a PI in those, around the side of PI in those. And because the PSCS to PSC incidence is low, either watch or do a PI, both we are justified. PI does not prevent all closure, and even if we do a PI, we still have to look for progression in closure. It does not absolve us from need for follow-up of these patients. Thank you.
Thank you, Thomas. So I'll invite Dr. Abhi Jacob for the next talk. Dr. Abhi Jacob will be talking to us on comparison of medical management versus SLT in newly diagnosed POAG. So SLT has rekindled the interest of a lot of people in the last few years. in view of the publication of the light trials. Even the long-term light trial results have been published, and they've been published from the UK. So we have a person from UK itself to actually speak to us about it. Dr. Rabi, please.
Good afternoon, everyone. It's a pleasure to be here. Thank you, Karan. Can I just ask by a quick show of hands, does anyone treat primary open-angle glaucoma or ocular hypertension as with SLT as the first choice? Anyone here? Okay. So that's a good start. It's wonderful to make a great diagnosis. Very happy with this one because this publication made the cover of the journal. So you can make these fancy diagnoses. The next thing is to decide what you're going to do, because we tend to give them drops, same as you. I mean, not very different. But we all know that all these side effects are there, and we are sort of committing our patients to a lifetime of miserable eyes. It's a horrible thing to be using drops. So we know that compliance with glaucoma medication is poor, okay? 90%. And these are studies from countries where, by and large, the cost of the drug is taken care of. Here, our patients have to go and buy the damn thing without insurance and things like that. So, lots of non-adherence, and there are so many reasons for non-adherence. And that, on the side, is a list that one of my lovely old ladies brought to me. Okay, that's a list of medications that she's on. And just about everything is an eye medication. Okay, and she has had it off and on, but she has been diligent enough to make that list. And I got that. I said, oh, I need to take a picture of this. So we all know also about SLT. It's not new. SLT has been used several times. For several years. Mark Latin is the one who popularized it. By and large, the shift from ALT to SLT has happened. So it's not something that is new, but nobody is using it. Side effects are hardly anything. These days, when I do an SLT, I don't even give the patient any drops or anything. Just tell them to take a paracetamol or a ibuprofen if they have to. But by and large, most people don't have a problem. And I'm sure you guys all know about the modulating effect of SLT on the trabecular muscle, unlike ALT that causes a burn. And it gives a good result. It gives a drop in intraocular pressure quite similar to latanoprost. Okay? And these studies were already there before light. I'm coming to light. Again, we also knew that there was hardly any problems with side effects, and we also got a good drop in the intraocular pressure over time. Okay? So, why are we not doing it? And that's where this proposal came to the NIHR. It is a big study. £2 million was spent on the study. I was lucky enough to have reviewed the paper from the NIHR. But this was done by Gus Gazzard and his team at Moorfields, 6 centers. And they randomized 718 patients into 2 groups, 362 with the drops and 356 with the SLT. And they use a strategy of having a target pressure and then treat the patient appropriately to get that target pressure. And they looked at the intraocular pressure effects, the control of the disease as monitored by all the tests that we do for glaucoma, and the requirement for surgery. And the interesting thing was 72% were at target IOP. It is 11 patients that went in for surgery, all from the medication group, none from the SLT group. And they also had, the NIHR model has a lot of cost calculation, and they also found out that it costs, in our terms, £458 less per patient at 3 years. So here are some of the results. Again, you can see that there's about almost 30% drop in pressures, but the most important thing, I think, is that reduction in the number of trabeculectomies. And then, of course, there is that reduction in pressure in progression between the two groups as well. The other interesting thing is the fact that the laser group had, very good control without any medications. A good number, 78%. Similarly, the evidence is now out there. They've come up with a follow-up paper for 6 years, and it shows that 70% are staying drop-free. And the other very interesting thing is that this study, I mean, not exactly, but it has been reproduced in Tanzania. Okay, that's a graph on the other side. But here they couldn't compare it with latanoprost because latanoprost is not freely available in Tanzania, so they used timolol. And again, good results. So our NICE got into action because there's 458 pounds to be made per patient. Okay, so they have changed their recommendations for the treatment of chronic open-angle glaucoma. The definition is funny for NICE. It is not pure POAG, it's also pseudoexfoliation and pigmentary glaucoma, which makes it a bit tricky. And even for ocular hypertension, now the recommendation is that you offer them SLT, not necessarily treat them with SLT. Okay, so I, sitting in my clinic, I do talk to them about SLT, but I don't really offer them SLT because I know that if I put them on the waiting list for SLT, it takes them about a year to get the SLT. So I have to start them on some sort of a drop, and then we have that discussion later on. Everyone else has also gotten to the act. That's the European Glaucoma Society, American Academy of Ophthalmology. So everyone's recommendation now is to offer laser trabeculoplasty as the first treatment for open-angle glaucoma. The problem with this is very simple. I mean, we know about all this. The problem lies there. When you have to do SLT, what it means is that you have to have someone who knows the angle to do the SLT. You can't leave it to the, in all clinics, you get the junior most person to do all the dirty work, okay? So this is time consuming, a bit tiring to perform. If you hold your hand up there and keep doing an SLT, it's not easy. And if you have a whole list of SLTs, by the end of it, you'll have neck pain. So I can see why it's not very popular as a first line of treatment, even in places where they can do SLT on day one. Okay? But that problem could be solved. Okay? Enter the Eagle from Belkin Vision. So this is a new machine that doesn't have a contact lens. Okay? Tick. 2, it applies the laser in a very short period of time. It applies 120 spots all around the limbus. And unlike the traditional SLT, which does the laser from the mirror on the body, this one applies direct. That's the big difference. The system has an eye tracker, so eye movements are taken care of. It's a touch screen. It's a very advanced scanner, so I think as a spin-off from that, you'll get better scanning technology. Oh, thank you very much. I didn't know that. Okay, and therefore, it is, I think, going to take over if they get their marketing right. The problem is, even though they say it is non-contact and no contact lens, you have to have a speculum, because we all know that you can't see the superior limbus if you just have a patient staring at you. But they have also gone ahead and done the studies to prove the efficacy and the safety of DSLT, as they call it. Pretty good results, comparable with SLT. So very advantageous. And therefore, you now have a dilemma on your hands. And that is, you have this option here, where you can put them on drops and give them all these problems. Or you can opt for this, The problem with DSLT is that it's quite an expensive machine. And to make matters worse, their marketing strategy is one of these. They are one of these companies that want you to pay per treatment you do. So it's a bit of a racket going on there. I'm sure it'll all be sorted sooner rather than later. But this is down to you, and you need to make the choice for your individual patient. Thank you very much.
I'm sure inquiries for the SLT machine will spike after this presentation. So Dr. Andrew Braganza will discuss whether you want to perform a trab or a tube in a primary glaucoma.
Good afternoon, everyone. And tube versus trab. By tube, we mean aqueous drainage device. So I've put that there. And we can look at it, and I mean, going back in history, we can look at it as a primary trab versus tube, which was the oldest study across all glaucomas. And we can look at it as the trab versus tube as first surgery in a primary glaucoma or in a treatment naive primary glaucoma. So our traditional treatment hierarchy is to first try medical, add on laser, then if there's a cataract, do a cataract alone or along with an MIGS, and then you do surgery. And you can do filtering surgery, you can do implants, and you can go on to cyclodestruction, and there are all sorts of combinations of these. And this is what our current flow chart looks like. And if you decide at the first diagnosis whether you're going to do go for medical treatment, then primary filtering surgery or primary tube, it would look something like this, and MIGS would have a role in intervening at various stages of this. So if we go and revise ourselves in tubes in specific glaucomas, then definitely tube is preferable to trab in neovascular glaucoma, uveitic glaucoma, many other odd kinds of glaucomas like ICE syndrome, aniridia, very often in traumatic glaucomas, very often in pseudophakic glaucomas. But that's not what we are here to discuss. The efficacy of the trab versus tube study, again on these kind of glaucomas, they were all previously operated eyes. They all underwent trab with mitomycin or a Barwelt implant. They both had similar IOP control at 5 years, similar additional medications, and the tube success rate was higher because part of the success was taken as the lack of additional interventions, and there were much more additional interventions after trabeculectomy. Now, if we look at the primary trab versus tube study, and these were all incision surgery naive patients. They did not even have cataract surgery. And their average age at recruitment was about 10 years younger than the trab versus tube study. The IOP control in their results was no different at 5 years. Okay, so it was about 13.4 millimeters actual IOP with the tubes and 13 with the trabs. There were fewer medications in the trab group. So it was 1.3 versus 2.2 with it, which was significantly different. But complications were more in trab, although this did not show statistical significance. There was no difference in the rate of surgical failure as defined in the study at 5 years, but the authors considered that trab was the most successful surgery. So that leaves us completely in the dark again. There have been a few publications by the authors of that study where they have looked at sub-analyses and tried to compare subgroups and see whether you can identify those patients who would benefit more from a trab or benefit more from a tube. And what they found was, what they really studied was, what was the initial IOP at the time of initiating the treatment. Those with a lower pre-op IOP did much better with the trab than with the tube. And this we can expect because really we know that if you would want to achieve a nice, good drop in intraocular pressure, you'll do a trab because you can even achieve single-digit pressures depending on what your defined target pressure is with a trab, which you can't do with any other surgery. The higher pre-op IOPs, however, showed slightly better results with the tube. And here I'm talking about the lower IOPs were 21 and below, the middle range of IOPs were 21 to 25, and the higher IOPs they defined as more than or equal to 25. So when you had IOP less than 21, there was significantly less surgical failure with trabeculectomy. When the pre-op IOP was more than 25, there was significantly less surgical failure with the tube, and this is their 5-year results. So what it seems to indicate is that you have some guidelines now for making a choice, but there are many facts to consider, and this is just my own thinking. There's really no major published data on this. There are some glaucomas where a tube is definitely preferred to a trab, and these are the secondary glaucomas. But in the primary glaucomas, the efficacy of the trab and the tube at 5 years is very similar with this study. The safety, okay, more short-term complications with the trab, but none of these have been major complications. All have been dealt with. The same amount of 5-year complications are there with both approaches. And the sub-analysis suggests that lower intraocular pressures, it's better to do a trab rather than do a tube. And with the higher intraocular pressures, it's the opposite way around. My question is, and what bugs me is, in the event of the failure of the primary tube, okay, you've got this patient who's a primary open angle glaucoma, and you've said, all right, his pressure is 26 or 28 or 30 or whatever it is, and I'm going to do a tube. And you do the tube, and he does well for 4 years, 5 years, but then it starts to fail. What will you add on to this patient? Okay, and I mean, when I say fail, I mean you've used all your maximal medical therapy, everything. But the pressure is still beyond what you have defined as the target pressure. What will you do? Is MIGS an option? No evidence. It may be technically difficult also to do it. And MIGS are not designed for great IOP reduction. SLT may be possible. Should we do a trab on top of the tube? It may be possible. It can be tried depending on the state of the conjunctiva. Can we do another tube? And to my mind, that seems to be the most logical thing to do, because you can stick a tube in anywhere, and you can even put the plate in the inferior quadrants without an increased risk of infection. Unlike with a trab, you have to, have superior trabs. And now we have more sophisticated ways of cyclodestruction, which can be better controlled, better titrated. We have the laser systems, which can be transscleral, micropulse, which again is something which is a bit iffy. And there is the high-intensity focused ultrasound, terribly expensive, but pretty effective. So all these are coming in, and we can possibly do that. But in our current state, okay, I would suggest that it's better for us to follow our treatment hierarchy as defined by the conventional wisdom of many glaucoma specialists over several years. I would say do a primary tube with higher IOP levels needing control, and a lot of this depends on the surgeon's own comfort with how, with what approach he uses. Some tubes and trabs will inevitably fail, and we have no evidence on how to proceed with this if we do these as a primary procedure for a newly diagnosed glaucoma. Logic suggests that multiple tubes is possible, multiple trabs may be possible. Trab following a tube also may be possible, but I'm not really sure about that. And controlled titrated cyclodestruction is coming in. Lots of new technologies are coming in, so we need to decide what we want to do. Thank you.
Thank you, Dr. Andrew. We will take the questions at the end of the session. So Dr. Thomas mentioned that the PI will reduce the risk of conversion from PACS to PAC by half. So whereas the other half also. So Dr. Ronnie will tell you how lens extraction and laser peripheral iridotomy, fight off against each other in primary angle closure disease.
So good afternoon, and I'll speak about this aspect of angle closure. So basically, what we hope to see after a PI is that the angle opens up widely. And this happens about 75% of the time in PSC and PSCG. Lens extraction also results in a widening of the angle. So both are considered as treatment options in angle closure. And we'll talk about what happens in angle closure disease, specifically in PSC and PSCG. We are not going to talk about acute primary angle closure glaucoma, and we're going to talk about these two conditions. Plato iris can occur in any of those situations, and that gets the other thing that we need to keep in mind. So what is the role of an early lens extraction versus YAG-PI? So Thomas has already showed you this, and this basically says that when you have PSCS and you're following them up, PSC and following them up, 28.5% progress to PSCG. 1 out of 9 eyes progressed in spite of a patent YAG-PI, and 7 out of 19 eyes progressed without a YAG-PI. And that was the basis for the decision, that's saying that all eyes with PSC should undergo an LPI, which is the guideline that we have been following. So if you have primary angle closure, there are two possibilities. You can either have Synechiae with or without raised IOP, or you can have no Synechiae but with raised IOP. All eyes undergo LPI. Post LPI, there are again two situations. One, you may have a persistent narrow angle post LPI about 25% of the time, or you may have open angles post LPI. So basically, from our point of view, in these two eyes situations, the problem is solved. We really don't need to do anything else. For these two, maybe there's a physiological basis for lens removal. The same situation appears in primary angle closure glaucoma. Occasionally, of course, you do get apposition persistent in Plato iris even after cataract extraction, and that's usually because of the presence of iridociliary cysts. Most of the time, cataract extraction does open up the angle. So this study was done to look at the effectiveness of early lens extraction for the treatment of PSCG. And it's the EAGLE study. So the questions that we have are basically, does it help with angle control? Does it help with IOP? And does it help with disease progression in terms of disc or visual field? And these are the inclusion criteria. So PSCG, you had to be more than 50 years, you had to have a field effect, or you had to have any of these changes on the optic disc. You had to have an IOP of more than 21 millimeters of mercury at least one visit. For primary angle closure, in addition to the narrow angles, you need to have at least one IOP of more than 30 millimeters of mercury. So it wasn't all primary angle closures, it was a highly selected group of primary angle closures. So you had to have 180 degrees or greater of appositional or synechial closure for inclusion. And the results, basically, they looked at two things. They looked at quality of life and they looked at intraocular pressure. Since this study was also funded through the UK, quality of life becomes an important thing for them, because when you're looking at public health, that's an important metric. And the difference in quality of life, and this is on a scale of 0 to 1, the difference was those who had lens extraction were 0.052 points better than those who did not. So 5% difference in the quality of life. In terms of intraocular pressure, a 1.2 millimeter better intraocular pressure control at the end of the thing. So in terms of the baseline characteristics, if you continue the clear lens extraction versus the LPI group, axial lengths were marginally lower, but significantly higher refractive errors in terms of hyperopia in the clear lens extraction group. So did the clear lens extraction removal of hyperopia improve quality of life is a question that has not been answered. In terms of, Second question is, what is the relevance of a 5% difference in quality of life? Is it actually better? If you look at the primary outcome, second primary outcome of intraocular pressure, you had IOP was 1.2 millimeters less in this group as opposed to the YAG-PI group. And this was actually less than the IOP that the study was designed to measure. They actually were expecting to see at least a 1.75 millimeter difference in IOP, and they saw much less than that. They were also supposed to see a 15% lower glaucoma surgery rate, which was not seen. So the study did not meet the minimum IOP criteria that they thought should be significant in order for the clear lens extraction to be primarily better. What about the angle? And this is the question that we have, because we said that our problem is not with in the eyes that where the angles open, the problem is with the eyes that where angles don't open. So this is at baseline. They had slightly less information about gonioscopy in the clear lens extraction group. There was missing data in this lot. At the final visit, 65% of patients had missing data in the clear lens extraction group, and 50% of patients had missing data in the YAG peripheral iridotomy group. in terms of the cynical angle closure, how much cynical closure was there was 60% data missing in both groups. So it doesn't really tell us anything about the angle, which was something that we're really, really interested in when we're looking at lens extraction. So our questions were, in the angle, there is no additional information. In the IOP, there's minimal difference, and disc and visual field changes were actually similar between both the groups. So in primary angle closure, lens extraction probably opens up the angle if there is residual closure. There's no justification for early lens extraction if IOP and angle are well controlled, and you should always do a YAG PI to see if the angle opens up. And if glaucoma surgery is planned, of course, you could consider adding surgery. So if are we justified in intervening surgically in eyes with PSCG with IOP controlled on medication that have a clear lens? At this point in time, there is no justification for us to do it. We should continue to do what we are doing, except in eyes with a very exaggerated lens fault. And even there, I would consider doing a YAG PI before I do anything else. So without significant cynical closure and open angles, the risk of progressive angle closure is very small. And the only advantage that you might have is to potentially reduce the number of medications. And also consider that this is a population where accommodation is important. Once you cross the age of 60, 65, when your accommodation is gone, it's a separate issue, but the mean age of the study was less than that. And cataract extraction is not without its complications in difficult angle closure glaucomas. So thank you, and I hope we have time for some discussion.
We have 10 minutes for discussion. If there are any questions to be asked, please go ahead.
Maybe in the SLT study, 78% of eyes were controlled at 6 years. Were medication 3 years in the,
Uh,
3 years.
I think
So,
70 something.
yeah, 78. But actually, what's really interesting there is that 68% of eyes on medication were controlled on one medication or less.
Yeah.
So that's fairly interesting because most of the time in practice, we don't actually see that number of patients controlled on one medication. So the actual difference.
See, I don't know. I mean, you've done trials yourself. Recruitment for trials is a very funny game. And there is also this thing called the regression to the mean. Okay. So it's very easy for these things to get into a very motivated sort of recruitment process. Okay. So, again, you do a lot of research, unlike the rest of us. And every research has to be taken with its own pinch of salt. So I personally feel that you may not get 70% in real life. Okay, your clinic is not full of open angle patients. Your clinic is probably more full of angle closure patients. Okay, so all those differences also need to be factored in, because again, if you have angle closure patients, this is not the treatment. And you'll find that a lot of them will get the treatment because your junior has probably not done a good sort of quality gonioscopy. So when you transfer these clinics, research data done in perfect situations into real life, the whole thing changes. But there's a huge, I mean, again, all of you guys have been practicing glaucoma now for decades. When you see a patient who's been on latanoprost for 10 years and you have to operate on them, your heart sinks. That is where the advantage is. If you can get 50% of these patients, on a laser treatment of this sort, you are on a win-win. You're on a win-win. I hope it sort of answers your question. Andrew? Yeah, go on.
So from a practical point of view, I mean, because you're in the NHS, how many SLTs are posted a day?
Very few. So again, like I said, that's why I said it during the presentation. If I post a patient for an SLT, he'll be lucky if he gets it in 6 months. 1 year is more like it. Then the question is, do you start him on topical treatment? If you start him on topical treatment, you have to arrange for that follow-up and whatever.
And also there is the evidence, there's some evidence that once you start them on topical treatment, it doesn't work that well. Right?
May not work as well. Okay, so your incentive is if you can treat them straight away. So now I do a, I mean I've started a new clinic where I see treatment naive patients. So there I can treat them straight away. So I treat them within the week. Okay, so next year I can talk to you about it.
No, I do offer ocular hypertensive SLT as first line of very, very early POAGs. But the rest in India, still everybody's still out of pocket and you're not sure how that works. And the second issue is, patients, once they have glaucoma, it takes some time for things to sink in. You do an SLT, we've seen patients who have had YAC-PI who will tell you that nothing has ever been done in my life.
Precisely.
So they just forget they have a problem.
Yes.
And they don't come back.
So that is true, because again we have these patients who have huge compliance issues, and when we are operating on patients these days, they would have been on treatment for 20 years, 10 years, 15 years, and then when you really go into their history, they have never taken this seriously in the first 5 years or 10 years. That is the area where this comes in handy, because you have done something which hopefully gets the pressure down and keeps it there. So yeah, I don't think it'll save you or anything on the monitoring, because you have to monitor these patients. Only thing is the eyes won't be miserable.
When you offer SLT as a first choice for ocular hypertension for our group of patients, like how do they approach it? Like we are saying that you have two options. Like one is to use medicines, the other is to have a laser procedure. So how is the acceptance rate of the laser procedure per se?
It's not bad actually. So most of the time I don't really start an ocular hypertensive on treatment at first visit anyway. Give them a little bit of time, see how they are. And I always tell them I'll do it in one eye. I'll see how it works. If it works reasonably well, do it in the other eye, otherwise you're down with medication. And for us, our SLTs aren't very expensive. Because we have got a combination machine, so we can cross-subsidize it. Yeah, the weaning off effect does happen. When they're treatment naive, sometimes you might land up with even 2 to 3 years of medication. So I have patients who have been off medication 1 or 3.5 years post. But yeah, some of them in 6 months' time. If it doesn't work, even sometimes in 3 months' time, you have to start.
But the weaning off effect,
you can, yeah, but that's, see, if it doesn't work for 6 months, there's no point in doing a second. If it works for 3 years, definitely do a second. Yeah, the second one data is there, but most of the second one data is done a little later. The ones which...
Yeah, but the weaning of effect, I mean, initially when the light results came up for 3 years, 78% was very impressive. But I thought what was even more impressive that 6 years, when 70% still continue to be drop free. That's, yeah, it's a big.
But the numbers are actually less at 6 years because they have some amount of drop.
Actually, we have not seen that long of effect, no. I mean, have you seen SLT working that long? Okay.
And after the publication of this app and analyst trials, how are the PIs in your office? Are they coming down or are they the same?
See, I think one thing which they don't talk about in this app and analyst trials, because I have had long discussions with both David Friedman and Tinong. And the thing is, they did their sample size calculation based on our Velo Eyes survey. And whenever they meet me, they would say, we are not seeing that amount of progression. So I asked them, what's your definition of progression? So their definition of progression is either an acute attack or half a clock hour of PAs. In most angle closure, you don't see half clock hours of PAs. You see those little pinpoint PAs. And the definition of progression in VES was a pinpoint PAs confirmed by 2 glaucoma specialists. So that's the reason that you're seeing much lower conversion rates. In fact, very interestingly, this is unpublished data, but we presented it at ARVO a few years back. The laser data, they're seeing about 5% progression in the eyes that had YAC-PI post-PACs. We're seeing about 11% in our Chennai glaucoma study where we did a PI for everybody. So that sort of explains it. No? If you're still going to continue to be basing it on that single PAs, the actual rates are double what you're seeing. And that's the reason for the low progression rates.
Yeah, one thing I've never understood, it sounds like a very stupid question, but what was the rationale for PI versus early lens extraction? Because you could obviously do a PI first and then subsequently lens extraction. Why the versus? I mean, I mean, PI is relatively such an innocuous procedure. Or
Because the quality of life benefit, nothing else. Otherwise, that was what they had to sell to the NHRC.
Yeah, if you look at the study more critically, the fact that gonoscopy was not there at inclusion and they're talking about angle closure means more cataract surgeons were involved in the